Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and Healthline 3 is where we like to focus on ways to help you live a healthier, happier, and pain-free life. So today joining us, we have Willis-Knighton Eye Institute. We have a familiar face, Dr. Christopher Shelby, and a new face, Dr. Kelly Coleman, joining us for our Healthline today. Thanks, guys, for being here.
Thanks for having us. It's always good to be here.
Absolutely. So, Dr. Shelby, we know your face, and we always know, typically where you are. We have your partner in crime that follows, Dr. Coleman, but today we have a new Dr. Coleman, and a prettier Dr. Coleman, I guess I would say.
Yeah, very much so.
Thanks for joining us, Dr. Kelly Coleman, and introduce us what you do, tell us all the things, and excited to talk more about your specialty today.
Yeah, so I am a fellowship-trained corneal, refractive, and cataract surgeon. I just recently joined the Willis-Knighton Eye Institute in January of this year. So really my specialty is cornea, so specializing in corneal transplants. I do offer full thickness corneal transplants as well as partial thickness corneal transplants. Typically the most common cornea things that I'm seeing are keratoconus, Fuchs dystrophy, corneal infections or corneal scars. Those are all implications to have a corneal transplant. So those are typically the things that I'm seeing in clinic.
Interesting. Okay, but you also do cataract and refractive surgery, similar to what you do as well, Dr. Shelby, right?
Yes.
I do,
Okay.
correct.
Okay. Yes.
Yeah, it's nice having her in practice because when I first started practice, a million years ago, I would do a little bit of everything, and I did a lot of corneal transplants, and this was actually before they had the procedure of endothelial transplantation, which is that very bottom layer of the cornea, which was not too uncommon to have it damaged at the time of cataract surgery. Of course, that's much less frequent now based on our technology. And it was always so brutal having to replace the entire cornea just for that one single layer. And when the endothelial transplant came out, I decided to either I could start doing that or I could just stick with cataract surgery, refractive surgery, and keep that in my wheelhouse. And so that's why I'm so glad that Kelly's with us, because not only will she do the full thickness corneal transplants, because like I said, I hadn't done one in a while, even though I did enjoy them, but I didn't really want to do the endothelial transplants. So having her here has been really nice for our practice.
And are you the only cornea specialist that Willis-Knighton Eye Institute has?
I am.
Okay, so and that just really broadens, I guess, the patient population that you're able to help too. Not only are you able to help, because cataract surgery, I mean, it's one of the most common, right, in America, maybe even here in the South too. So you're helping out in that regard, but then also providing another specialty for those that need it. So that's great. So tell us, okay, so you both do cataract surgery, but since you have the cornea specialty, Dr. Shelby, tell us the difference kind of between cataract surgery, and then maybe you could kind of come in and say, like, okay, this is what is different in terms of the cornea specialty. Does that make sense?
Yeah, it does.
Okay.
Well, and there's quite a bit of overlap, and the other Dr. Coleman, her brother and I, we did a lot of cornea work ourselves, but a lot of the more complicated things we would send out to some of the other cornea specialists. And with cataract surgery, like I said, there's a lot of overlap, and with cataract surgery, we're removing the God-given lens, because as you know, the cataract is just a browning of your lens. We remove that lens and put a new lens inside the eye. With refractive surgery, what we're doing is we're changing the shape of the cornea. And so that's where there's that crossover with Dr. Coleman, is that we do LASIK, which is create a flap, then do the laser, PRK, we scrape the surface of the eye. Sounds horrible, but it's really not. And then do the laser, or SMILE, which is small incision lenticular extraction, where we make a cut within the cornea itself and then remove that. And so the purpose of those procedures is to improve uncorrected vision. Like you wear contacts, we can do the surgeries and get you out of the contacts or glasses. The more complicated cases then would spill over into Dr. Coleman. I mean, things like cross-linking, which is where we drop riboflavin on the eye and shine a UV light to help with keratoconus, prevent those patients from going blind or needing a corneal transplant, that's when Dr. Kelly comes into play.
Okay, yeah. So tell us, where that crossover is. So sometimes you will be working on the same patient, I presume.
Mm-hmm.
Yeah.
Yes, correct. So like Dr. Shelby was saying, so after cataract surgery, sometimes you can have some swelling of the cornea after the surgery that does not clear. And that could be due to dysfunction of the innermost layer of the cornea that pumps the fluid out of the cornea to keep it clear. So sometimes after cataract surgery, if there's swelling that does not clear, that is an indication for me to see them to be evaluated to transplant, remove their own inner lining of their cornea and transplant it with new healthy cells to clear the cornea again. So that's part of the crossover. Also, patients that have pretty severe Fuchs dystrophy, where they just naturally have poor function of those endothelial cells, that inner lining. Sometimes I can do a what's called a combination surgery, where we do the cataract surgery as well as a corneal transplant at the same time, because we know that those people are going to have difficulty clearing that swelling after surgery.
Okay, and I know that the workup for your patients, it's pretty extensive, so that would be something that you'd be able to tell during that workup of, okay, they're going to need both cataract and the other procedure that you mentioned.
Yes, correct.
Okay.
Yeah, so a lot of times, let's say Dr. Shelby's been seeing a Fuchs patient for 10 years and it's time for cataract surgery. He might send them over to me to evaluate to see if we need to just do the cataract surgery and then monitor the cornea, or if we just need to go ahead and do both surgeries at one time.
Makes sense. Okay. Well, we have our first caller, Sheila. Thanks for joining us. And what is your question today?
My question is, I had cataract surgery in 2019. Now, I'm not happy because I have to wear readers all the time. Is there any way that I can go in and have the new fancy lens, I'll call them, implanted?
Sheila, that's a good question, and we get that question quite a bit. There's a couple of ways to approach that situation, and number one is, we take a look at you, because obviously what you have in is monofocal for distance, and they're probably working great, but you're having to use readers for everything up close. And look, I get it, I understand. I'm over 50, so I'm wearing readers a lot of the times. So one way to do it is monovision, which if you're a good candidate for LASIK, we leave your dominant eye for distance, and then we make your non-dominant eye nearsighted. So when you're using both eyes together, you can see distance and you can read up close without glasses. And we can actually test you with that with contact lenses. So, we make sure you're a good candidate for it. There are options as far as doing what we call an LAL piggyback, where we put the light adjustable lens inside your eye on top of the lens that's already there. And then we can make adjustments based on, how we want to get your vision. But removing the lens you currently have and then replacing it with the multifocal at this point is a little more difficult than if it were to be done within like the first 6 months or a year of having the surgery. We would just have to take a look at you and see.
Okay. Now, I did have the LASIK surgery done on one of my eyes in 2020. But I still didn't have the results I wanted.
So after,
or I would like to have.
After LASIK, so you had cataract surgery in 2019 and then LASIK in 2020.
Yes, sir.
Okay, and then do both eyes see well at distance?
Yes, sir.
Did you ever do monovision? One eye distance, one eye up close?
Sir.
You ought to come in.
I tried the contacts, but I could not wear them.
Well, and honestly, let me tell you, it's not about when we try somebody in a monovision contact, at least in my clinic, it's not about seeing if you can get used to the contacts. It's we put the contact lens on to make sure you can tolerate the discrepancy between the two eyes, right? So you've got one eye distance, one eye up close, and that throws off depth perception a little bit. And most people love it, but we do it to make sure you don't hate it, if that makes sense. And it's one of those things that's easy to test, and you can come to any one of our locations, and we can test you out with a contact. We're not going to make you put them in and take it out. We just want to make sure that you could tolerate that. If you like it, and most people do, like 85%, then you can have another LASIK procedure to adjust the vision. Actually works amazingly well.
Okay, so it would be worth coming in to see if it would be suitable for me.
Yeah, absolutely. I mean, and just because we're not going to jump on you and start operating immediately. We're going to look at you, go over the options, and then show you what it would be like if we were to do that. And so,
okay.
If you like it, great. If you don't, nothing lost, nothing gained. Then we can look at other possibilities.
Okay, great. Thank you very much.
All right, Sheila, you're very welcome.
Yeah, thanks, Sheila. And if you're just joining us and you have a question for Dr. Shelby or Dr. Coleman, you can give us a call. That number is right there on your screen, 318-219-4569. Okay, so back to you, Dr. Kelly. Tell us why you decided to pursue this field of surgery. What interested you being an ophthalmologist and then also specializing in corneas?
Yeah, so I initially got interested in ophthalmology because of my brother. I shadowed him and spent some time with him in clinic and surgery, and that's really what sparked my interest. And then throughout my medical school journey, doing rotations in ophthalmology just further solidified that that's what I wanted to do. Cornea specifically, I just had a great experience in residency with our program director who was a cornea specialist, and just the impact that you can make on a patient's life, improving their vision from a corneal transplant or a corneal procedure can just make a huge life-changing difference. So that just really impacted me and motivated me to go into cornea.
Love it. Yes, and do you have to have a extra specialized training?
You do. It's an extra year of fellowship training. So I completed that the year after my residency, graduated from my fellowship, and then started here in January.
Nice,
Yeah.
nice. Okay, and I know that you both see general, do general eye checks, right, with your patients, but you also do the surgical aspect. So can you tell us the difference, either one of you, the difference between when you go and see a general ophthalmologist just for your annual eye exam, and then the difference between that and seeing someone for cataract surgery or your specialty as well? Like, do you have to have different training for those two subspecialties? Does that make sense?
Mm-hmm.
Okay, go ahead.
Yeah,
take that.
and usually, what I can tell you, of course, there's 5 days in a week, well, there's 7, but we try to narrow it down. And I used to try to be everything to all people, and you just can't.
Yeah.
And so now we have partners in our practice. We have a lot of optometrists, medical ophthalmologists, PAs that see just routine cases. You need glasses, you need contacts, you have an issue, you can come in, because a lot of times we're in the operating room. And so when one of them see a patient that says, oh, you have a cornea issue or you have cataracts, then they'll generally refer them within the clinic to us, and we'll see them. And like in mine, I mainly see cataract surgery or refractive surgery candidates.
Gotcha.
And then if I find an issue with a pre-op or a post-op cataract patient that has a cornea issue, then I will refer them to Dr. Kelly. And so it's this internal referral network, and we try to keep it like that so a patient doesn't have to wait months to see us, and somebody can see them right then and there.
Right, so it probably just also depends on the doctor and what you're interested in too, and what you'd prefer to spend your time doing, I
That's
guess,
correct,
at that
yeah.
point. Yeah, because you can't be everything to everyone, unfortunately.
No matter how hard you try.
Yeah. Well, Greg, thanks for joining us, and what is your question today?
I've got a question. With cataract surgery, once they remove the lens, is it absolutely necessary to replace it with a artificial lens? And if so, what are the pros and cons of not having one replaced?
Yeah, so I'll take this question. So anytime we remove a cataract out of your eye, we absolutely have to put a new lens inside the eye in order for you to see. The cataract is the natural lens inside the eye, and so that is why when we remove that cataract, we do have to put a lens inside the eye in order for you to see. If we left you with nothing after removing the cataract, you would have very poor quality vision. So it is essential that we put a lens inside the eye.
Okay, great. Thank you very much.
And that's something that that you guys would talk about probably in that first maybe initial consultation with that patient, right? And maybe what their goals are, like you were talking about with Sheila. You know, are you able to? Do you want the mono vision? Do you want to be able to see at distance? Those kind of questions, I'm assuming, right? That you'll cover, so you can pick the right lens for that patient.
Yeah, the beauty of cataract surgery nowadays. So, back in the day, let's start with even 40, 50 years ago. It seems like a long time, but it's not. Cataract surgery was fairly brutal. It was a big procedure. Patients were in the hospital for like 2 or 3 days with sandbags on the side of their head because the complication rate was so high. And even before then, when the lens was removed, it wasn't replaced. And so they were aphakic. And when you don't have a lens inside your eye, you don't have that part that focuses light. So they had to wear aphakic spectacles, these really high magnifying glasses. Now our technology is so good that if you come in with cataracts, it's like, okay, we can get you seeing much better, but we can also make it to where you don't have to wear glasses most of the time. We can correct astigmatism, we can correct distance, intermediate, and near vision, and we can do all that with the lenses that we have available.
Nice. Earl, thanks for joining us. And what is your question today?
Yes, ma'am. I want to know if y'all could help me any with seeing how to drive.
Seeing how
I can't
while
see
you're driving?
I cannot see colors sometimes, and it's real foggy. It seems like a fog on in my eyes. I can't see good. I just can't see good. I'm scared to drive.
Dr. Kelly, you want to take this one?
Sure. So that could be, a variety of reasons why you're not seeing well, but most likely the most common reason why you're having difficulty driving is likely due to a cataract. That is typically the first complaint that people complain of with cataracts, specifically with nighttime driving. You have a lot of difficulty with glares or halos at nighttime with bright lights to where you feel like you're unable to drive at nighttime anymore. That is most likely a cataract. And so what I would recommend for you is definitely come in for us to evaluate you, and we could do a full eye exam on you and figure out exactly what is causing your difficulty with your driving.
All right. Can you make me an appointment next week?
I'll tell you what, you if you call our clinic and tell them you talked to her on KTBS, they will make you an appointment ASAP.
All right. Sounds good to me. All right. I'll do just that. Do what now?
And that phone number is right there on your screen. If you're able to maybe copy that down, or you can also look up Willis-Knighton Eye Institute on the internet, and you can find a phone number that would connect you with one of the doctors.
Yeah, and you can go to thecataractsurgeons.com and find any of our 3 locations there.
I would read it out, but I can't see that.
I know, because you need LASIK.
Yeah.
So
my eyesight has gotten worse
okay, we call it job security.
Right. Okay. Anyways, moving on. So one of the questions that I had that you mentioned, even 40, 50 years ago with cataract surgery, just it's vastly improved over the last several years. Do you think it's because our life expectancy is like people are living longer, and so you're probably performing more surgeries? Am I making sense there?
I think it's just, so innovation is driven, just by human beings in general.
Right, yeah.
And so, and you've got a lot of people out there much smarter than me that are like, oh wow, hey, what about, this and that, and being able to, put these lenses in to allow patients to see better. And it just evolved from there, from not only the lens itself, but the materials that are used in the lens, the surgery that's been done, and the way we do it, and just the technology. I mean, the physicists at a lot of these companies like Alcon, Bausch & Lomb, and whatnot, are really brilliant in what they've been able to do, because optical physics is not easy, and these guys have created these platforms that allow a wide range of vision. And I've been putting the multifocal lenses in since they first came out. They are so much better than they were when we first had them that it's unbelievable. But it's no different than like RK back in the day. I never did RK, but radial keratotomy, which is making an incision inside the eye, I mean, those patients are very difficult to deal with nowadays because it causes so much corneal irregularity that it's not done anymore. But when you talk to all of them, they'll tell you it's the best thing I ever did. You know, they're like, it was wonderful. I could see so well for 7, 8, 10, 12 years. And now we're almost spoiled with what we're able to do now. And so it's just that the innovation's driven. And the longevity, now that people are living longer, and they're not only living longer, but they're healthier, you know, and so they're more active. And that's driving a lot of the improvement in functional vision, you know, so you don't have to wear glasses, even in your older age. But also patients are coming in sooner having cataract surgery.
Yeah.
You know, because cataract surgery used to be such a brutal procedure and complication rate was high. I mean, there's still some old docs out there that'll tell you, well, your cataract's not ripe. I never knew what ripe meant. You know, and nowadays, if your vision, kind of like Earl was saying, is at a point to where it's affecting your quality of life, it doesn't matter what you can read on the chart, it means it's time to do something about it, you know.
Yep, great insight there from, you know, and it's just interesting to see, even in just the last 2 years that I've known you, the things that you've been able to add to your practice, just the technology and the advancements and things like that too. And I'm curious to see, you know, what will happen in the future too. So, so going back to corneal transplants, this is Dr. Kelly. This is like your bread and butter, I guess. Now, when you are saying transplant, and you said something about adding those healthy cells. Where are you getting those cells from, and what does that process look like?
Yeah, so all of the cornea tissue that is used for a corneal transplant comes from an eye bank. So it is from deceased people that donate their organs. So the cornea is harvested by these eye banks, and they prepare and store the tissue, and then we request tissue whenever, you know, I'm planning to do a surgery for a patient, and the eye bank will actually send us that tissue. So it is actually from a donor.
Gotcha. Okay. Interesting. And do you have to have like a perfect match, like similar to a blood donor when it comes to something like that?
You do not actually. Okay. So the cornea is avascular, so it has no blood supply. So you don't actually have to do a perfect match per se, like other types of organs that have blood supply to it.
So that's nice, I guess, in your case. So it's, you know, it's maybe easier to have that supply for your patients. And do you, I mean, and I guess it just really emphasizes the importance of donors, you know, and organ donors, and why that's, I wouldn't even think that you would need something like a corneal transplant, and that you would, you know, potentially need that from an organ donor. So very interesting. So, you know, how is that done? How is the corneal transplant, you know, done, and how do you know if someone needs that specific procedure?
Yeah, so specifically for the endothelial transplant, which is just that inner lining, again, that all just has to do with the health and the quality of those cells on the inner lining. So specifically, the most common indication for it is Fuchs dystrophy. Okay. And so that is just if it can be genetic, where you start to lose the overall quality or the number of those cells, to where you just don't have the ability to keep that cornea clear because those cells are not pumping the fluid out of the cornea to make the cornea clear. So that's the most common indication for an endothelial transplant. As far as a full thickness transplant, where we actually remove the entire cornea from the patient and transplant an entire new cornea, the most common implication for that is keratoconus, which we do cross-linking for in the more early mild stages. And so we always want to do cross-linking as soon as possible to stabilize the cornea, to prevent you from ever having to have a full thickness corneal transplant in the future. That's the most common indication for a full thickness. Also corneal scars. So if someone's had a previous injury to the cornea, typically it results in a big scar formation, which can significantly affect the vision. People that have had corneal infections in the past can also lead to scarring. Or if someone has a really active corneal infection that is just not getting treated, could be an implication for a pretty emergent full thickness corneal transplant.
Interesting. And what are some of those symptoms that's, maybe even different than a cataract, or are they similar symptoms that someone would experience in those conditions?
As far as keratoconus, this typically presents in a younger population, teenage years or early 20s. Typically, you just notice a pretty rapid change in vision over the course of 1 to 2 years. So if you go get a new pair of glasses and then 6 months later to a year later, those glasses just are not working well for you, you go in for an eye exam and your prescription has changed significantly, you have a lot of increased astigmatism. That is kind of the classic signs of keratoconus. As far as like a corneal infection, that's going to be the typical eye pain, redness, or discharge from the eye.
Yeah, and your eye should never be in pain. If it is, then there's something majorly wrong, I'm sure.
Yeah, I remember pain and blurred vision are always abnormal.
Yeah.
I mean, from baseline,
Right.
Obviously, you can't read the numbers on the screen, so that may be your baseline. But if it's, you wake up and your eye hurts or your vision's suddenly blurry, you need to, something's going on.
Right. Yes, and you want to get that checked out for sure. So, so what other treatments do you guys offer? I guess combination of both of you guys, so that our viewers, if they're unaware, how can they get in touch with you to, of course we know cataracts and cornea transplants, but what are maybe some of those other things that you offer that we haven't talked about?
Some other things that I offer are some cosmetic procedures. So I do offer what's called Morpheus 8, IPL, Forma 1 treatment for dry eye treatment, as well as Botox injections as well. So I do bring some of that cosmetic aspect to our practice.
Okay, nice. And so, we wouldn't have known that otherwise, because that's not necessarily associated with the eyes. The Botox or is Morpheus is not as
Morpheus
well, right?
8 can treat skin resurfacing, skin tightening, overall, just general better appearance of the skin. It can also treat what's called festoons, which is under eye bags. So Morpheus 8 can help with that as well.
Interesting. Okay. Yeah.
And she did Forma on her brother.
I did.
Oh, really?
Yeah, she did.
You don't want to go see maybe Dr. Shelby for that, right?
No, I mean, you can. I can get on YouTube, but like I said, that's not my wheelhouse. Although, full transparency, I've got festoons. I've had them, look just like my dad. Not a bad thing. But the RPA, who also does it, she did the Morpheus on me, and there's 2 more treatments, and so far so good. I figured, might as well give it a try, but it really works well, especially the dry eye treatments that they do. Is amazing how well it's worked for these dry eye patients that before have thought, well, I guess I'm going to be stuck with artificial tears for the rest of my life, and now we've got diagnostics. We can really narrow down what's causing their dry eye, and a lot of these patients are getting relief that they haven't had in literally decades.
That's amazing. Well, cool. So we have 1 minute left, and where can we find you, Dr. Coleman and Dr. Shelby?
Yeah, my clinic is located at the Willis-Knighton South location off of Burt Coons. I operate and do all of my cosmetic procedures at the Willis-Knighton North location off of Greenwood Road.
Okay.
Yeah, and of course I'm at North too. That's where I do surgery. My clinic is at Piermont. It's 212-3937. Dr. Coleman's number is 212. I never can remember. Your brother gets so mad at me. What is it?
I don't even know.
Okay, so go to thecataractsurgeons.com. Thecataractsurgeons.com. All 3 locations are on there. Everything that we do, plus our contact information.
And there's a number on the screen that I still can't read, so you can take a picture of that
Yeah,
too.
well, if it makes you feel better, I really can't either. It's for
It's a little,
212-2020. That's
Anyways,
easy.
I should come see you guys. Okay, thanks for joining us. Be on our website, ktbs.com/podcast.